it's such a pleasure to be part of this symposium, this Rayner Symposium. When we look at the literature, it's clear that diffractive optics are associated with unwanted halo and optical phenomena. And this does include trifocal implants, as you see in this comparison which was previously published. We also know that newer diffractive optics, such as trifocal lenses, do provide something that was missing, which is intermediate vision. But if you look at the trifocal, this is the bottom layer on this display, you can see there is better intermediate, but it's not as good as either the distance or the near. It's not that impressive. So, by definition, extended depth of focus is quite simple. Rather than splitting the light, we take the single point of focus and we extend it to provide a greater range of vision, including intermediate and near vision. And there's many ways you can do this with optics. You can use diffraction as the J&J low add diffractive bifocal or the low add trifocal, or you can use phase shift technology such as in the Vivity lens. But you don't have to resort to diffractive optics, and it is possible to increase the depth of focus simply by manipulating spherical aberration, either negative spherical aberration, or as I will show you, in my opinion, preferable with positive spherical aberration. It's most interesting to look at the defocus curve. So you look at the logmar acuity from -2.5 to +2.5 diopters in the half diopter steps. You can see the extended range of focus of the positive spherical aberration EDF IOL as compared to a standard negative spherical aberration IOL. And this curve gives you some insight to how to use this clinically. Because if you then put the extended depth of focus lens in an eye with modest monovision, -1.25, you can see the greater overlap between the distance and the near eye. And this is even exaggerated if you use a positive spherical aberration IOL in both eyes. The overlap's greater, and you don't really have monovision, you really have blended vision. If you compare, and this is from actual data of patients implanted some years ago, you can see that the bilateral defocus curve using this lens is quite distinct from the defocus curve of a diffractive optic, a bifocal diffractive optic, and different again than the defocus curve of a trifocal optic. And the biggest difference is the intermediate vision, which is really excellent in the extended depth of focus IOL. And a lot of our activities today are more intermediate based with digital media, etc., rather than reading small print, perhaps in years gone by. Now, most important is the quality of vision. And when I compared the contrast sensitivity with the same patient but different lenses in each eye, found it very difficult to find any difference in impact comparing the positive spherical aberration optic to a standard negative aspheric optic, both for topic and mesopic contrast sensitivity. So when you choose an optic and an optical solution, there's always a balance between quality of vision and spectacle independence. And I would suggest that total spectacle independence is not perhaps the ideal parameter to judge patient satisfaction. And this is the quandary that you may have a patient who's totally spectacle independent with a multifocal, but still not happy with the quality of his vision. And when you look at the options and the balance between quality and reading ability, I would suggest that an extended depth of focus or monofocal plus lens such as the RayOne EMV, based on positive spherical aberration, gives you that best balance.
The title says what I'm going to discuss, reality or myth. And we'll use a tool for that which is objective, which is and optical bench testing. Now you see diffraction seems a bit like, oh, diffraction means halo. So, and at the time of the EDOF symphony, it was said by the manufacturer that this lens was not really diffractive, but it was. Now there are true non-diffractive IOLs on the left, which are the ISOPure, the Technis, the Luxmart from BNL, and the Rayner, which is different from all the other I cited because this is so far the only monofocal plus which uses a positive spherical aberration mechanism, as was highlighted by Graham in the lecture. And so we are more maybe familiar with how it works. And there was also the introduction a couple of years ago of a new IOL and EDOF monofocal plus. I don't know how to say what it is, but it was designed by what it was not supposed to be by the manufacturer. Again, it's designed first as a non-diffractive IOL, which is bizarre to me to design something by what it's not. But this is a claim to get the eye or the IOL with a wavefront focusing, stretching X-wave technology, which is also putting like a question mark because all lenses are stretching the wavefront in some ways, else there would be not any optical interaction. So we are facing the challenge of unclear IOL optic definitions, technology descriptions, and this is why it triggered us in my department to investigate these advanced optic and see really what they were in the eye. And when you look in the eye, for example, a RayOne EMV lens on the left, and you compare it to a Vivity on the right, you see it's clearly different. I wouldn't be able to say that the lens on the left is refractive monofocal or refractive multifocal because it's smooth. But on the right, I see, and you've seen it if you use that lens or seen patient with, those little concentric zones which evoke or can evocate a diffractive structure or element or a combined refractive diffractive structure, because as soon as it's abrupt, there's diffraction, optically speaking. So you can see clearly the ring-like structure on the Vivity, and you don't see anything on the Rayner. And now we can try to compare this to what the manufacturer provided as a description, and we were pleased to see that it's very similar to what Rayner disclosed, so at least there is some transparency here, not only in the lens material, but in the communication of the element provided to the doctors, and I think this is enjoyable because it's not often the case, and you won't find many description of IOL diffractive structures in other competitor booth. And now the Vivity I alluded to, as you can see, the profile extracted from the base curve has an intriguing shape. It's not to say a kind of a full diffractive IOL, but it certainly has diffractive structures. Again, see the height of the structure is about 1 micron, very low, and it's sharp, it's not smooth and continuous. So there must be something which any physicist in optics would describe as a diffractive element. It's not a bad word, it's just a physical truth that we should be aware of to better judge what we do. It doesn't say the lens is good or bad, that's not my point. I just try to stick to optical reality there. So, the Vivity show possibly a diffractive element there. Now what about the Rayner? The Rayner has been measured also. It provides positive circular aberration. This is a wavefront of either element. And what's interesting is when you measure several lenses, that's Benjamin's graph here, he measured several spherical elements, IOLs, the EMV, which is the blue, and other lenses using negative spherical aberration, and you see that the lens provides a constant spherical aberration throughout most of the optic, and it's positive. And it doesn't go up much toward the edge. On the contrary, it goes down to preserve optical quality for large pupil diameters. And what you see here is that for average pupil diameter, which is 3 millimeter for most patients, physophakic patient, and average spherical aberration, which is usually between 0.2 0.3 microns positive, the lens has the highest depth of focus. You can see the scale here, almost 2 diopters, 2.5, and outside of this zone, still it performs well, providing 1.5, 2 sometimes, or around those values of depth of focus. and that makes this lens quite robust also to pupil dynamics when it comes to increasing the depth of focus. So in conclusion, we showed that Rayner is a company that so far accurately explains their advanced technologies, and I hope it will continue like that. It's a fully non-diffractive IOL. I'm speaking about the EMV, and I think the depth of focus has been shown to be at least 1.5 diopters or more throughout all those combinations. And I think we now need to learn more about the in vivo measurement to see if they're in line with those findings. Thank you very much for your attention.
We had 48 patients in this trial, and we did target for half a diopter of mini monovision, because that's something I like to do in practice, and that's what we did in this trial. And the outcomes, the main outcome was difference in binocular uncorrected intermediate visual acuity at 66 centimeters, so that is the main outcome, and then obviously we measured all other things as well, but that's what the trial was powered to. This is just to show you the implantation process. As you know, the lens is a pre-loaded lens, is a hydrophilic acrylic lens, has a very long track record concerning the material. Also, this, in this case, we're seeing the EMV toric, which was introduced into our trial a little later on, because when it became available, we started, of course, without the toric component. And as you can see here in this image, you do not see any diffractive elements, because there are none, and you also don't see any central zones of any kind, because it really does look from the outside like a monofocal lens. So this is the comparison of the two groups, which were randomized, as I said, and you can see here that these are the targets we set for the dominant eye and the non-dominant eye concerning target refraction. These were the kind of exams we did at 2 weeks a few, but main outcome at 3 months. And you can see we did a whole host of things apart from the visual acuity measurements. A little worse at distance, as you can see here, if you look at the details. And that's something we also hear about the Vivity, and that's also my clinical impression, having used the lens quite a bit, that there are some patients who say, for distance, it's just not as good as they would expect. So these are patients who are quite critical, and that's an answer you get once in a while. And I think that that's something we hear from several surgeons. What about contrast sensitivity? You can see here in black the RayOne EMV photopic, and then photopic with glare. Here photopic, and down here for mesopic. And in red you can see the Vivity photopic, and then including glare. And you can see that the Vivity actually is lower than the Ray EMV in pretty much many of these spatial frequencies. What about halo size? You can see that the halo size for the Vivity is larger, and that's also statistically significant. Here you can see the box plots for the two. There's obviously always some overlap, but these are the averages, of course, throughout the entire perimeter. So to conclude, we had this mini monovision trial of half a diopter comparing a monofocal plus lens, the Rayner EMV, with an EDOF IOL, the Vivity. You can see the differences here in the postoperative refraction on the non-dominant eye, just to, again, show you the slight difference between groups. We saw no significant difference between groups for distance and intermediate vision. This is uncorrected. But we did see better uncorrected near vision for the EDOF IOL. There's a trend for a slightly better contrast sensitivity with the EME group, especially under mesopic conditions with glare, as you saw in the one graph. We didn't see a significant difference regarding reading speed. This is actually for intermediate, I'm sorry. We did see a difference regarding reading speed for near. The photic phenomenon, the EMV had a smaller halo size.
So this was a retrospective study with 6 months of follow-up comparing the RayOne EMV with the Acrysof Vivity lens. We looked at objective assessments, visual acuity, refraction, and subjective outcomes using the RayPro questionnaires for patient satisfaction. 820 eyes of 517 patients were included. These are the preoperative considerations, and you can see that about 300 patients in each group, which is the majority, had bilateral implantation, with the minority having unilateral implantation. Most eyes were targeted for emmetropia, so everyone had emmetropia targeted in the dominant eye. And in the non-dominant eye, it varied. And of note is that 10% more eyes had a more myopic target in the Vivity group. so minus 0.75 or more. The eyes within the NHS normative values of plus or minus a half or 1 were excellent in both groups. So what do we see? Well, we saw, as you've heard in the other studies and in the theoretical studies, but it's nice to show in a big kind of, let's say, real-world retrospective study, that there was a statistically significant better uncorrected distance visual acuity and corrected distance visual acuity in the RayOne EMV group versus Vivity. What about the questionnaire? Well, we sent this out to 300 patients who were binocularly implanted, and we received a response from 42%. And satisfaction was excellent with both. In this group, it's not only cataract patients, also refractive lens exchange patients, so maybe a little bit more demanding. But there's 84% satisfaction with the RayOne EMV and 78% satisfaction with the Vivity lens. We presume that difference in satisfaction to be due to either tolerability of mini monovision or the improved reading, the improved distance vision that you get with the RayOne EMV. It clearly matters to patients. So in conclusion, the RayOne EMV demonstrated significantly better uncorrected distance vision and corrected distance vision. Intermediate vision was equally good between the two lenses. We saw good uncorrected near vision in the EMV group, but slightly better, 3 letters better in the Vivity group. But expectations were matched or even surpassed in the EMV group, given the difference in lens design and how the lenses are actually positioned in the market. And that difference in reading vision may actually be explicable by the fact that we targeted a little bit more monovision in the Vivity group. We saw more effective postoperative cylinder reduction in the EMV toric group and higher patient satisfaction levels in the EMV group. Thank you very much for your attention.